sir.
minutes, sir.
Already we are in live.
Yeah, we are live now.
Okay. Good morning to all. Welcome to ExRxIndia's and Sri Samraj Health Services Private Limited for the students webinar series, and we are moving towards a world record event. This is not a competition. This is to bring out the confidence and the talents of the students, especially. And now we are having Mr. P. Jeevan Kumar from UCA College of Paramedical and Sciences, and his topic is Physiotherapy Management of Amputation for Lower Limb. I welcome our ExRx team members, Dr. Rupesh and Professor Duna, and now I welcome our student category resource person, Mr. P. Jeevan Kumar. Please.
Thank you, sir. Thank you, sir. Good morning to all. Before me starting the session, first of all, I'm thanking ExRx team, Chandra Mohan sir, and also Duna ma'am, and also Rupesh sir. Thanks for the opportunity given to me. And also, in that time, I have to represent my college, UCA College of Paramedical Sciences. Thanks for motivating to me, our principal sir, Sandhir Kumar sir, and the vice principal sir, and also my friends and family. Thanks to them. Now I'm going to start my session. Thank you, sir. Okay, now I'm going to start the session. Today we are going to see about the physiotherapy management of the amputation for lower limb. Okay, it's me, Jeevan Kumar from UCA College of Paramedical Sciences, State Pet Chennai. Okay, first we see about the preamble. Amputation. First of all, we see about the definition. Amputation is defined as the surgical removal of a part or a whole of a limb, and on compare if recently I'm searched about these statistics while I'm taking to this topic. There's a more number of lower limb amputations are done maximally around the world. It's due to many of the traumatic conditions. So I picked this topic for amputation management for the lower limb. So that's why I put that point in between. On compare with upper limb, lower limb amputations are done maximally. Particularly, most of the amputees are young age and have commonly age starts from 15 to 65. Why it's come for amputation for 15 to 25 is maximum is about the cases of traumatic conditions. We will see about that in upcoming slides. Yes, next slide. Now, indications. The persons who are undergoing for amputations, they are traumatic condition. That's the thing of first I'm saying. Most of the cases in here are they are amputation cases, which are they are caused due to 1 second. Sorry for the inconvenience. 1 second. Sorry. Okay, now I can search. Now I'm continuing. Indications, traumatic conditions. Most of the persons who are youngsters, they are went to a bike accident or any other traumatic conditions, which is leads to them in the crush injury of the bones. So it leads to the amputation of their leg. And then vascular conditions, Buerger's disease, osteosclerosis, arteriosclerosis, gangrene. Buerger's disease is nothing but it's a artery and vein diseases is formed on the hands and also some in the hair legs. Arteriosclerosis, it's again the bacterial infection diseases. Gangrene, it's a condition which is caused in the diabetic patients, and also neoplastic conditions. Malignant tumors will form on the persons who is affecting with the tumors, which is causes which amputation is done to the it cannot be spread to the all over the body, and some of the infective conditions like leprosy, actinomycosis, filarial elephantiasis, these are all done to stop the spreadage of to the all over the body, and also some of the congenital conditions like grossly deformed and useless, because if some persons will have that lower limb foot is very just it is grossly damaged and it cannot be used like properly like now normal persons. So it is congenitally it is amputation for the clinical purposes and physical and for improving the physical and functional purposes. Okay, now see about the types of amputation. So what are the types of the amputation which is done here? First one is gluten amputation. It's called as, again, another term, emergency amputation. It is a life-saving measure because in it is a, if an any traumatic condition, that is if someone have a lost their leg in a accident, there will be loss of so many bloods. So again, emergency, he's admitted in the hospital and he's undergoing for a gluten amputation, and is the doctor presents amputating him for the emergency purpose to save him, to save his life. So then we see about the classical amputation. These amputations are planned amputation. These are done to the patients who are diabetic conditions and gangrene and some of the infected diseases. So to stop the spreadage to the body, especially this amputation maximum is done to the foot and lower limb, because it starts from the lower limb. So the amputation is done to the lower limb. It is called as planned amputation. So this is another type of amputations. And also third one is revision amputation. It's a second stage of gluten amputation, and also for other planned amputation, because if someone amputation, the end of the amputation is it's not satisfied for the patient and also the doctor. So the person who is amputated already is going for again and second amputation to complete a satisfied amputation. So that is called as revision amputation. Okay, now we see about the some of the levels of it's not some it levels of the amputation of lower limb. Here, this picture represents what are the levels which is present in the amputation of lower limb. First, quarter amputation. It is amputated within at the level of hip, and then hip disarticulation from the below the hip. It will disarticulated from the portion, and then above knee amputation or transfemoral amputation. It is amputated on the femoral level above the knee level, and then through knee amputation. It's amputations done at the level of the knee region also, and then below knee amputation or transtibial amputation. It is done above the below the knee. So for the life-saving features, and then SAMS amputation and forefoot amputation and toe amputation. While talking about the amputation, I have to register one more amputation, that is auto amputation. This is not by done by the clinical practitioners, because it is automatically amputated patient themselves, because they lost their senses at the tips of the fingers or tips of the toe foot due to the diabetic conditions. They frequently get injured at the same portion, but they did not know about that they are injuring there, and loss of sense due to loss of sensation, that some of the tissues will lose step by step, and then it's loss of it leads to loss of one toe or second fingers. So it is named as auto amputation. Okay, now we look at the pre-operative management. First of all, again I'm saying, teaching the importance of the exercise to the patient is very must, because they have to do exercises regularly to maintain their strength and the use of prosthetic upcoming days after the surgery. Okay, first of all, what are some of the exercises which is we have to taught to the patient? Diaphragmatic breathing exercises and segmental breathing exercises. In diaphragmatic breathing exercises, we will stimulate the diaphragm muscle to make them give a beautiful respiration. And also some patients have lung complications. So we have to give first diaphragmatic breathing exercises and then segmental breathing exercises. In segmental breathing exercises, you can give stimulate the breathing by giving segmental movements like apical, lateral, and posterior, anterior, like that segments. You can stimulate segmental breathing exercise through the exercises. And ankle toe movement on the normal leg. You have to tell the patient to you have to do ankle toe movement on the normal leg for the loss of there is, if you do these exercises, there will no need of accumulation of swelling on that. You have to tell the patient. And also active RM exercises for normal leg, and also both for upper limb. We have to teach the patients before the preoperative management. We have to and also we have to mentally ready the patient for undergoing for surgery. We have to tell about it clearly about the patient about the surgery also, it and the importance of the surgery also. Then he is mentally prepared, and he had the fight that after the post-operative, I can able to good and very well to do my work itself. So that's the thing we have to provide them. Okay, we will see post-operative management. in postoperative management, we will divide that short-term goals and long-term goals like that. First of all, in the short-term goals, bedside mobilities, improve sitting balance, improve standing balance with support, improve walking balance with support. Basically, all the surgical conditions have short-term goals and long-term goals. But in this condition, in the patient will absence of one leg, or sorry, one leg, not one half of the leg. It's based upon the conditions, or it's based upon the surgery they have done. So we have to step by step, and not on the particular days. We start it on the days. We start it on the upon the strength of the patients, and also long-term goals, which comes under built the confidence of the patient, that we have to motivate the patient to you can do yourself by our exercises and regain all active iron in unaffected site. That's it. That's the meaning. Is and if we cannot do the sum of the all the free exercises on the affected side on first itself. So we have to give those exercises to the unaffected side, and also as well as the upper limb. Realize the importance of exercise throughout ACs or limb. Improve the stability of standing and walking with the prosthetic fatigue. It's a main important thing. First of all, we in short-term goals, we improving the walking and stability balance with the support in the short-term goals. On long-term goals, we improving the stability of standing and walking with prosthetic fitting. That's why we are giving training itself in the short-term goals. Okay, we will see some of the complications, which is I put it about some of the very common complications which is come to the patients. Yearly complications. First, infection. It will for some of the patients will have diabetic or any other hypothyroid or thyroid patients will got infected because the wound is not healed soon. That's why they got infection and have secondary hemorrhage. The suture is not very well sutured because of the health of the condition, and so it will leads to secondary hemorrhage and skin clogging. After the amputation, that part of the amputee, the stump of the amputee is leads to some of the skin clogging. If we were not stump care, if we do the proper stump care to the patients, and late complications are contractures. Contraction of the muscles which is present above the amputated part, and stump neuroma and phantom limb. And phantom limb, it's nothing but it's sorry, the amputation patient, after the amputation surgery, he feels like a presence of on the same leg, and he's tempted to he wants to walk at the same leg with the two legs. After the realization of absence of leg, he will feel like okay, there's no leg, but I think like that sensation is like phantom limb sensation and phantom limb and phantom pain also. Okay, now we see about the early post-surgical evolution. Okay, after the surgery, we have to evaluate the patient. How evaluate the patient? How is the patient? How is built? How is comorbidities condition? How is cardiovascular and respiratory functions? How is his pain? It's a main important thing. We have to see the dressings of the patient. There's three dressings are there. That is rigid dressing, semi-rigid dressings, soft dressings. In rigid dressing, it is the first dressing after the put after the surgery done by the orthopedicians, which is for to hold the skin to neglect the skin slogging, and also muscle wastage, and also some of the fluids have to come, and it is put for wound healing. And semi-rigid dressing. Semi-rigid dressings like the elastic garments, elastic tight garments, which is done by the patient, which is we can able to do, and for it is done for the neglecting the skin slogging and wastage of contractures and wastage muscle wastage and the absence of the contractions. And soft dressings. Soft dressings comes under the stump care activities. He has to clean the stump regularly and inspect the stump for any infection or any some of the oozing out of the functions. And also if you have to put soft dressings like crepe bandages for the post-operative complications of the amputations. Okay, now we will see about some of the managements which is taken for the amputation patients for the what are the exercises we will see. Okay, first of all, exercises for AK and BK amputation. That is above knee and below knee amputation. In this slide, I am representing that mainly for the transtibial and transfemoral amputation exercises, because those amputations are more prone in these cases. Actually, there's statistics is there. You can search it in the internet. Most of the amputations are for amputation is done for young generation, and in that young generation, most of the amputation is transfemoral and transtibial. In that transfemoral and transtibial is morely done due to traumatic conditions. Okay, so we will teach some of the exercises with them. I'm shortly saying here, and we'll briefly explain it in next slide. Okay, first of all, we have to give free exercises for all the active RM exercises, resisted exercises, active resisted exercises for lower limb to activate strengthening the upper limbs to maintain that crutch walking and that frame walking, balancing exercises, standing in the parallel bar, walking in the parallel bar. Then only he got that confidence to walk towards the parallel bar, and then he will try to without support in the walking. Then resisted exercises using weight cuff and TheraBand. Okay, in these resisted exercises, we can use DLAMS method. I will say about the DLAMS method upcoming slide. Okay, next slide is, yeah, this picture represents the free exercises and some of the isometric exercises for the transtibial person. Okay, first exercises, A is represents the quad set. In that person, that arrow mark shows under the anterior part of the thigh, there is a red mark is there. That is the contraction of the quadriceps. So the person or patient will leads to tries to contract the quadriceps. That is called quadriceps sets. That is isometric exercises. And then in B, you can see that in prone lying, the patient is tends to hip extension with the knee extension. That is one more exercises which is given for the extensors of the knee, hip and the knee. And also in C, you can see straight leg rising, SLR, which comprises them quadriceps and hamstring muscles to straight leg rises. And then D, he is actively doing those exercises in the normal leg to retain the original position of that, and you have to push that amputate leg towards the ground. And in E, you can see that resistant exercises is given. It is a step by step. It have to come after the achievement of those exercises. We have to give the resisted exercises using TheraBand or resistance band with the hip abduction against resistance. So patient has put in the supine lying. We have to tie that resistance band around the both legs. He has to do that hip abduction properly. And in this if fracture, you can see that patient is doing pelvic bridging by holding those arms in the above the chest, and with the help of the towel support, he is placing his amputee knee on the amputee leg on the towel and lifting his another normal leg. So you can clearly see in this way picture, and I'm able to understand. I think in this by doing this bridging, he can be able to activate those muscles which is present on the amputated side. Okay, so it will stimulate the muscles slowly, and then regain its strength properly. That's it. Then we will see about some of the exercises for transfemoral patients. Yeah, in this picture, same gluteal sets are done. You will see that first picture represents that arrow mark are coming inside, which is in prone laying also, and is in supine laying also. It's simple. That person in this picture is contracting the gluteal muscles alone himself to. It's like a static contraction without weight bearing. It's kind of free exercises. Whenever he's trying to, whenever he's achieving good contraction of these gluteal muscles, then he's go for next exercises like resisted exercises. Same also you can see in B picture B. TheraBand resistance is TheraBand is tied around the above the femur. Above the femur, it is given for the resisted exercises, hip abduction in supine with resistance, and also hip abduction with resisted in C. Also we given in is side lying. Okay, we giving the resistance to them hip abduction, right? Okay, first B picture represents that is in supine lying. Okay, C picture represents in side lying. So what is the main difference between them? It's nothing. It's simple difference. While we doing in resistance the exercises in supine laying, for that abduction of hip, it is go along the gravity. Okay, gravity is it's very less in that position. If you do that same exercises in side laying, gravity acts more on that position. So that's why we doing the same exercises in supine laying and also in the side laying. Okay, again is the person doing the hip extension in the prone laying, and also E represents a bridging. So somewhat this for transfemoral and transtibial are same exercises, but we have to select the exercises based upon the conditions of the patients and also amputation of the patient. Now we'll see that for standing balance exercises, a component surface on a component surfaces. It is standing for the improving the balance of the patients. It is suitable for both the transtibial and transfemoral amputation patients. He has to improve their position, and he has to improve the standing balance without support. That's the training we have to give. We can use any mat or rough floor, which is suitable for the patient's foot, which is able to stand at that position without support. We can use that floor. Okay, next we see that prosthetics. Wow, it's a good topic. Before that, some of the exercises we giving that preparation for the prosthetic training. Whenever we improve the muscles of the amputation area and some of the unaffected areas and upper limb, as well as whenever we give that strengthening protocol to them, he is able to do that prosthetic training very well. On when we talk about the resisted exercises to the amputation area, we will give white cuffs and DLAMS method. We will try about the DLAMS method. DLAMS method is nothing but it's a technique of resisted exercises. First of all, we giving half cage, and then 1 cage, and then 2 cage. We repetition, we increasing the maximum weight to that limb, and also first the patient has to done that exercise start from half cage, and he has to do that same weight with the maximum repetition of numbers. After that, some rest, and also he has to done with 1 cage and give some maximum repetition of number with 1 cage, and also again we give some rest between, and then we doing that exercises. This technique is called DLAMS method of resisted exercises to that patient. We can done these exercises before the prosthetic training. Before the prosthetics providing the prosthetics, we can give that trainings also again also. Okay, now while because of I'm talking about the transtibial and transfemoral amputation exercises, I'm showing there what are the prosthetics which is used for the transtibial and the transfemoral prosthetics. These are the types of the transfemoral and transtibial amputations. First three is for first three is for above the knee, and the first two is for above the knee, that is transfemoral. In between is also a transfemoral, and after that last three it's for transtibial processes. Okay, now we look at the prosthetic training. For before that, we're giving the prosthetic. After we give some exercises to achieve that strength of the able to do all the ADL activities by the patient. So we give those exercises. After the giving prosthetic, we have to give training him to overcome those weights which is come by the prosthesis. So we have to give some training to the patient. So let's we see what are the prosthetic training. Before that, we have to know about the main thing. The major goal of the prosthetic rehabilitation is for the client to attain a smooth, energy efficient gait that allows the individual to perform ADL and participate in desired employment and recreational activities. So it's a main important goal is for the prosthetic training is that a patient has to attain its perform ADL and participate in the desired employment. He has to employ, because he is also have family. After this some traumatic conditions, is economically they will be suppressed, so he has to go for employment. So we will motivate them for some of the employment and some of the recreational activities. Okay, we will see about the prosthetic trainings. First, we have to teaching them about the stability control, and then knee control, and then stepping down and stepping up control, and then prosthetic control on static options and prosthetic control on dynamic action. These activities are done under supervision with support and with the fitting of the prosthetics, and then proprioception, and then pelvic control, and then stepping with processes without support. From proprioception, pelvic control, stepping with processes is are done without support. First five is done with support with prosthetic fitting, and the last three is done without support with prosthetic fitting. Whenever he is achieved more stability and knee control with support, he is able to act without support, individual alone. Okay, now we will see the pictures of the how we stabilize the knee. Here, the person is putting that this technique is both for the transtibial and transfemoral. Okay, so whenever the person is able to stand stability in that with the fitting of the prosthetics, and the therapist have to give some object, and the patient has to reach that object without any collaboration. Okay, so this picture represents that type of exercises that is improve the stability of the person who's wearing prosthetic. Okay, now see the second picture. In this picture, we will see that knee control. First is the person standing without bending the knee and with the support. You can see those parallel bars. He is standing in between the parallel bars, and by holding those parallel bars, he is very confident and try to more concentrate on the exercises. That's why we training with the prosthetic fitting first with support, and then training them without support. Okay, first in first picture in first person does not bending his knee, and then he's bending the knee. By this we can control the we can use that knee control and give exercises, we give control to the knee control for the patients. Okay, now we will see that picture. In this we again with talking about the stability of the processes. It is both for the transtibial and transfemoral. While this we can you can see that this picture also contains the same with support, that is the person is standing in between the parallel bars. We can give some steps like a footstool or any other stools which is slightly or 4 inches or 2 to 3 inches height only. The person has to step up and step down with the normal leg and also with the affected leg, so that otherwise he can improve his stability allowed. And then we will see the fourth picture. Yeah, here in this side you have to see those pictures at a time, because in the first picture you can see that the ball is in the normal exit. For what is the represent side, it is also for the prosthetic and the stability control. He has to kick that ball by giving the weight on the prosthetic leg, and he has to kick that ball in the normal side. Is that only first picture represents. On the second picture, the person has to kick the ball with the prosthetic leg and bear the weight on the normal leg. So by step by step, we can improve the stability and control of the prosthetics to the patient. We will represent that. Okay, wait, we will see the next slide. Again, one more picture. This is represents the proprioception of the patient. See that person is standing in the without support. After the achievement, all those things in the before slide as shown. After that achievement of those things, he is come in this without support. He has to stand in the numbers which is put. You can see those numbers 12, 6, and 9. Other side number which cannot be shown. So with the he has to slightly forward. We have to set that number. For example, the patient is in front of me. He is standing without support. I'm judging him for the proprioception control. Okay, I'm saying a number. Okay, sir, you have to put your leg on the number 10. He has to put his number on that limb, that is prosthetic leg. He has to put that, and then we can use it in two types. First in affected leg, first in non-affected leg, unaffected side. First we can say that affected side, he has to put the numbers which is commanded by the therapist to the patient, he has to put that number by the prosthetic leg and then unaffected leg. So this practice is called proprioception training for the both transtibial and transfemoral training. Then we will see next picture. Yeah, here we will see the pelvic control. Yeah, because here we will start the standing and weight shifting to each pelvic side. That's why we will again put them in the parallel bars with support. Whenever he's trying to put the weights on the one side, on the other side, we have to hold and support the knee, pelvic side to give a support and also improve the confidence. Because whenever he's trying to lift his one leg, he is able to stand good at a tall time. Okay, next we will see those pictures. Yeah, these models you can see that they are walking without support. First picture shows that he's stepping that sound side, that is affected side, forward and backward. In second side in second picture he's holding that sound leg, that is affected leg, and moving his normal leg forward and backward. And that picture says that the sound leg is laterally movemented, and again that normal leg is abducted. Okay, you can have a doubt which side is a normal leg, which side is a sound leg. The stick is the stick which is drawn only off is the sound leg, and which the stick which is go through full is a normal leg side. So like that only we will improve the stability and knee control and pelvic control of the patients, and bring them out with the prosthetic fitting from support and with unsupport. These are the techniques which we will use to for the transtibial and transfemoral patients, and also some of those exercises which is given to the patient. Now, let me summarize these slides. Okay, first of all, I'm saying about the surgical removal of a part or whole limb is called amputation, and it occurs mostly in youngsters in traumatic conditions like example crush injuries. And then major is transfemoral and transtibial amputation occurs. It is not said by me, it's a it is said by the statics, which is presented in the internet alone. And then we will talk about the post-operative trainings given prosthetic fitting. That is some of the exercises we will start as isometrics, and then free exercises, and then assisted resisted exercises, and active resisted exercises, and free exercises for the all AR active ROM exercises for the upper limb as well as the unaffected leg of the lower limb. And then we talking about the prosthetic training is given to achieve ideal of the patient. After the prosthetic fitting, we have to give the training exercises for to improve the knee stability, and also improve the basic balance of the effects, and also do the actual activities of daily living like bathing, toileting, and also everything that's including grooming and going for a shop and shopping itself. These are all come under the activities of daily living. So he is trying to build towards this prosthetic fitting. These are the giving comes under this slide. Okay, let me conclude like this. Conclusion: physiotherapy plays a major role in the rehabilitation of amputation patients. Based upon the assessment of the patient, treatment protocol is written. Again, and I'm saying it's just a protocol. This protocol will change day by day, and also in each and every individual, because some patients will very built and smart, will very built and good in built. Okay, so they can able to do, they can easily achieve those resisted exercises within a 3 days. But some patients are very feeble, so you have to give those assistive and isometric exercises to them for a 3 to 5 days also. So that's why I didn't put about the post-operative days, because it's changed very well. It's not same for all the patients. It's mostly changed for the all individuals. Okay, and then it's in this recap for AK. In this slide, I was talking about the AK and BK, that is above knee amputation and below knee amputation, that is transtibial and transfemoral amputation. Like this, all the amputation case, physiotherapy plays very important role in the rehabilitation, like in upper limb, above elbow and above below elbow, and wrist amputation and shoulder level amputation, and also science foot amputation. They have to put a shack foot and also Jaipur foot also put that. Main thing is the prosthetic fitting is done for the prosthetic prosthetic specialists, they have to measure and put the prosthetics to the patient. We just train them for the prosthetic fitting, and then after the prosthetic fitting, we train them to do the all the ADL activities and outcome of the functional independence. Okay. It's, I think you enjoyed this session. Thank you for listening this session very well. Thank you.
Thank you, Mr. Jeevan Kumar. You have a very good oration skill.
Thank you, sir.
And the way you presented also very nice, and the message you have covered biosocial model also, and proper exercise techniques. Everything you have covered in a short period. I'm proud of you, and a very good informative session. I thank you for that, and I thank Dr. Sendil Kumar, Principal, and Dr. Pasupati, Vice Principal, UCA College of Paramedical and Sciences, for sending their students to contribute for the students, by the students webinar series. I thank all the participants. I thank Jeevan Kumar, and I thank ExRxIndia team members. I thank you all. We will meet you in the next topic. Have a nice day. Bye-bye.
Thank you, sir. Bye, sir.
Bye-bye.
Well presented.
Thank you, sir. Thank you, sir.